All right, hello everyone. We are going to go ahead and get started. I will briefly introduce myself. Ya'ate Shike Do Shidene She Corvina Sabiku Yanishe Tachini Nishle Hawatlane Bushishteen Tohoglini Dashache Maidishkijni Dashanele Akot Ego Dene Atsane Nishle Rochester, Minnesota Khashte Shabbat, New Mexico De A Nasha Mayo Clinic De A Nashnish. Good afternoon, everyone, my relatives, my friends, all who have joined us in person and those virtually. It's great to see everyone today. I introduce my maternal and paternal clans. This is how I introduce myself as a Navajo woman. I am Navajo and Jemez Pueblo. I currently reside in Rochester, Minnesota. I am originally from Shiprock, New Mexico, and I work at the Mayo Clinic as a research program coordinator under the Center for Health Equity and Community Engaged Research. I have my master's in public health from the University of Arizona, so I am a wildcat. I also have my bachelor's in community health from New Mexico State University, so I'm also an Aggie. But I'd also like to give props to my hometown community college where I did start my journey, which is Dene College, so I'm also considered a warrior. I am grateful to be relaunching the speaker series, Indigenous Health Topics, which was previously known as the Native American Interest Group, run by the prior Native American Research Outreach Director, Dr. Wes Peterson. I am happy to be able to carry forward the speaker series, which brings us all together to learn and spread the wisdom, expertise, and experience of our guest speakers. Our Indigenous Health Topics speaker series is focused on hosting local, regional, and national experts in health education and research to present on topics that have an overall impact on our Native American Alaska Native communities. These meetings will be hosted monthly, every third Thursday of the month during this noon hour, Central Standard Time. There will be opportunities to attend virtually and in person at our Rochester campus. With all that said, I would like to introduce our first speaker of this series, Dr. Rebecca St. Germaine. She is a data research scientist, educator, and health administrator. As an enrolled member of the Lac Coeur d'Alene Band of Lake Superior Ojibwe Nation, Rebecca works collaboratively within tribal communities and outside health agencies to improve health conditions through education and advocacy at the primary level. Her research area examines developing and evaluating health economic impact within rural health clinics. She authored the Cultural Health Approach to Health model that provides a clinical model of prevention, intervention, and post-evaluation method that focuses on predictive factors of tribal culture and behavior. Dr. St. Germaine utilizes and promotes culture determinants that relate to the health status within addiction studies and social determinants of health at the policy integration level. Rebecca received her PhD in social and administrative pharmacy from the University of Minnesota College of Pharmacy. I'd like to please welcome Dr. St. Germaine to the podium.
Thank you, Ms. Massa. Thank you very much for that kind introduction. And we are humbled today when we consider the great strides that we have come through this last COVID epidemic, this last opioid epidemic, the various things that cause our people to take a step back. You know, we're in an area where weather is really important to us. Sometimes it rains, sometimes we have huge winds. And in the Indian way, we talk about those times where the Creator says, maybe it's time for a step back, you know, a time to reflect, a time to stop what we're doing and look around us and see how we can help others. So much of the time when I look at tribes, when I look at the intersection between healthcare, policymaking, and tribal supports. Looking at the clinician level and what they are dealing with, it's an open avenue, actually. It's an opportunity. Much of the time in literature or, through peer research, through even the news media, there always seems to be challenges. But what I've learned to do is look at it as an opportunity that we can really focus on the things that are meaningful to us. And I think at this time in our career, politically, social, globally, this actually is an opportunity for us to really change what we're looking at and bring in those quality times, whether it comes from our own family, our tribe, our neighborhood. And so this picture is actually a drop off. When tribes were getting vaccines, what did that look like? For many tribes in the states, in Minnesota and Wisconsin, the tribes were the first entities to receive the vaccines, but it didn't come easy. So was that a challenge? Yes. But that was also a time that we said, hey, these are heroic events. That's pharmacist right there carrying Melissa Opsahl. She's the head of IHS Pharmacy. She didn't send somebody else to out to do it. She literally got in the helicopter, strapped herself in, and started carrying vaccines to tribes, which also now to counties. And so that's also my disclosure that I have nothing to disclose other than what it's like for Indians, and tribal people. So this was in 2020 when the vaccines rolled out. So contents today, I'm going to go through some framework, some approaches. Now, these kinds of approaches and framework are, they're not basic. They are fundamental. They are required. They are some things that clinicians and our critical care teams probably should be aware of when we start working with tribal people. It works. So the cultural specific health belief model, I codified that in 2019. Cultural specific health belief model actually is a way to look at the identity of your patient, of your client, of your stakeholder, of your partner, of your family member. Whatever defines your community, do it a priori. And there's a reason for that. The basis of this is identifying who people are, who people say they are when you first meet them, when you first greet them. What is their perception of health? And for the first time since the ACA, we have this ability now to talk to our providers. Once upon a time in pharmacy, not too long ago, 15 years ago or so, 10 years ago, you really couldn't get a pharmacist to talk about medications. You always heard the same response: talk to your provider, go talk to your doctor. But now a pharmacist, PharmD, can actually discuss medication. Physician can tell you more about the medication. There was actually a dichotomy between the physician staff and a pharmacist, what they could tell you and what they did not tell you. So the cultural specific health belief model can apply to not just Native Americans, but to all different community of people. And I think that was really well reflected in what happened in the state of Minnesota with the George Floyd. How important is that we identify, a person and what they believe, what they think, who they are, and how does that affect us moving forward then on to therapy, compliance, adherence to medication. So the impact of COVID really put a spotlight, put a focus on these perceptions of health. Am I sick? Am I well? According to data, the EPIs will love this. According to data, Native Americans top all the data columns, everything from chronic disease, conditions, practices health. We have some of the strongest people in our health belief systems. We have also the other side of it where we have the impact of diabetes and meth and heroin. And when COVID hit, when we went under state of emergency, for the first time, we had to actually address, what do we do with the meth and heroin addicts that are our family members? Do we put them out? They're already out on the street. Do we bring them back in the home? On reservations, they had to come back into the home. Whose home? Many of the people that I work with in meth and heroin are homeless. They're also poverty stricken. They don't have that luxury of going to different places. So within a very short time, Minnesota actually is one of the leaders in, as well as Wisconsin. We started topping charts, the 911 calls, the fire department calls. We're handling up to 37% of ODs. It wasn't fires, it was Narcan. So, of course, this actually is a word cloud taken from maybe about four months ago now. What are people talking about? COVID. Zoom actually topped the list. So the data practices really help to support some of the early movement here in identifying and addressing what people are saying. And there's something called NodeXL, which is a cluster algorithm that literally picks up what's on the tweets of Facebook and social media. So if you want to know what people are talking about, you can go to NodeXL and put in a topic, headaches. Lots of people come in with headaches. You can Google it and go through it, find out what happens. So the gap statement that I'm seeing here is many health models omit this very crucial step, the a priori identification of who the client is, who the patient is. I'm going to see if I can minimize this bar here. There we go. I used to do a lot of these quotes and I'd give out prizes to people, if they could answer things, look under your chair, see who you get. But so I just did one. This is actually from a physician, non-native, Caucasian, about his African American patients with uncontrolled hypertension. So a lot of questioning, and what I read in that is, he's wondering, am I really addressing the person? I can treat the symptoms, but am I addressing the person? What am I not hearing? So much of the time we do research, what we're looking for is the questions not said. Am I asking the right question? So actually this should have been on a thing, but I got A and B up here now. So on the right, A is actually the cultural belief model. It starts for Native Americans, when they go to the doctor, much of the time we end up down here, we're at the outcome. Some of the time we're up here at the construct. What's bothering you? The conditions that we see as outcomes of illness right here is what the practitioner might see. You have diabetes, you have edema, you have possibly cardiovascular disease. So we tend to hover around the middle area here, and that's going to be important as I go on in the next 2 minutes. But for Native Americans in particular, whenever we've been brought up within our homes, within the ceremonies, within the cultural practices, we're always told about the oral traditions, and sometimes we take that for granted. What are historical influences that really define a tribe? Are you from here? Are you from? And we heard the introduction earlier. She described her mother and her father's side. That's her identity. That would fall into the cultural specific health belief model. She identified who she was at the very beginning. I know as a provider, I may know how to treat her, certainly how to address her, certainly how to respect her perspective on health. because that would inform me of what would be what she would like to maybe see within her healthcare. It's easy to give out a prescription and a pill. It's easy to hook her up to an IV. It's more important to look at the next 40 years of her life. So that's where Indian people, I believe, we have to change our approach, that knowing that we get maybe 1 or 2 instances as a provider to see them. Pharmacist sees them every month, you know? So what are we teaching our students? So when I do teach students, I remind them that this isn't just a point of care contact. This is a forever contact. And if you want to be involved in a person's life, listen to how they first talk to you. And if they haven't identified themselves as Native in the beginning by their name, by their tribe, by something, maybe we could ask. So changing those scope of questions, like what we're taught in medical school, what we're taught in pharmacy school, change the questions. That isn't done yet. When I get grants or I talk to clinicians, I ask, what's the origin of your questions? They're CDC questions. How old are they? 25 years old, you know? So that's just what happened recently. And I said, well, yes, you're working with tribal people. We need to develop this. We're all researchers here. You know, we're always talking with the grants people. We need to take some time and readdress those questions. What are those characteristics? What are those things that are taught in our medicine lodges that really would make a difference? When I work with meth and heroin addicts, we've opened up 2 shelters and 2 treatment centers, and we had the highest rate of sobriety on abstinence in the state of Minnesota. So during COVID, when we shut down in state emergency, we opened up a men's shelter again. And I asked for the felons, give me the felons, give me the addicts. And they said, nobody can take them. Jails can't even take them. I said, send them over. You know, we'll give them socks, toothbrushes, clean pillowcases. They'll be safe. We'll address those social determinants of health. We'll address them as they are. Meet us as you are. It's the same thing like working in the ER. You meet them as they are, you know, but you're safe. So the education component of this model, education and instruction, we need to educate each other. And that's where as clinicians, you might hear congruence, competency, et cetera. You know, we do that piece, but we have to do a little bit more. We have to actually bring in the speakers, bring in tribal people, bring in community leaders to let them actually tell you what are the issues. And then, because we have been through medical school and graduate school, we know how to categorize what this should look like. Or we employ other statisticians to actually do this. The graph on number B here is actually, if you recognize this is a very simple health belief model. Perceived threat, demographics, etc. How did you find out that you were actually ill? How did you find out there was COVID vaccines available? Do we do anything about it? Well, for an Indian people, a lot of them didn't trust the vaccine. So some of them took it, some of them didn't. Same thing like addicts. Some of them take the prescribed therapy, some of them take the medication. But what we find is in the middle section there with that little red circle, they feel that it hasn't been addressed in the very beginning. So the modifying factors, it's kind of a modifier. Oh, by the way, there might have a Native American in your, in your clinic or in your treatment center. So in the middle. The end part is maybe they've gone to the treatment, maybe they've gone through the therapy, whatever pharmacotherapy is available, and now they can go back to their people. You know, we send them back out the door. But for the cultural specific approach, we've addressed it at the very beginning. And from there on, this whole framework actually might change, because the things that we have perceived as being a threat may not actually evolve as a threat. When we work with meth addicts, everyone, you know, from social workers, from the county, from the judicial system said, you know, they're not going to straighten up. They've got problems. They have poverty level. They have low education. But that wasn't the case. So in Minnesota, the greater part of natives in Wisconsin and Minnesota actually are in the rural areas. And the latest projections of population is overall 70%, 76% of American Indians now live in urban areas. Very few of us live on a reservation. So I still live on Lakota Reservation, which is, this is Fond du Lac, so I'm about over here in Minnesota, in Wisconsin. But I work down here. Why this is important, because the data that follows the state of Minnesota only really captures tribal. They're not capturing the other half. When speaking with Native Americans, they always refer to themselves as the things that are important to them, whether that would be their tribe, male, female, some of the things they've been involved with, traditional activities. Do they fish, hunt, gather? Do they participate? Powwow season is right now. Do they go to the powwows? Do they see healing or traditional healers? I didn't ask, do they listen to them, but do they see them? Do you go to sweats? You know, do you acknowledge them, that they exist? Do you acknowledge that there's another power there? I never asked, do you drink? Do you smoke? Do you do the other part of it? But do you acknowledge that there's another life? So the cultural expression. I put in there cultural expression and happiness, because what I found in the last data set from Dr. Walls, she did probably the only data set that encompassed 5 tribes, but actually 26 were represented in her sample. And I did a discriminant analysis, and what I found out is, while they had the top categories for suicide, depression, chronic disease, comorbidities galore, every kind of that you can imagine, 93% regarded themselves as being happy. There must have been maybe 6 questions on happiness. 96%, 93% said they wouldn't change who they are, even in the face of all these, unfortunate circumstances, abuse, domestics. Would they change who they are? And I was floored to see that. This went out to 5 tribes, 26 tribes were represented, and it was clearly across the board. 93, 96% were happy. And that was phenomenal, because that isn't published. We don't hear about those things, that Indian people are happy being who they are. So that caused me to take a step back, because in pharmacy, we like to push those pills, push those things, get on Seroquel, get on all kinds of things to make you feel better about yourself. Do I need to be doing that? When I worked in Thailand, and there 87% of the people still do traditional medicine. So I asked them the same question. Are you happy? Are you happy each day when you get up or go to bed? Life is hard, I know that. But are you happy? They were happy too. I said, would you take pills to make you more happy? And they said, no. Why? Because if I were to look on your sheet according to your blood work, this should be happening to you, So it's the question. Are we actually asking the right questions? And sometimes when we get older physicians in here, it's easy to talk to them. In fact, I hire them because they've learned to say, I don't need a lot of things. Give me my bag, give me my scope, I'm ready to go. Because what are you going to do? Oh, I listened to their heart. I was 6 years old when I first realized I was going to go into health, because there was an old EENT doctor at the time, and he was at Evanston Hospital. He was head of his department, etc. But every Saturday he would come into the church, into the community center there, and he'd have his nurse in his metal chair and his sandwich, and he'd sit on his chair, and the little kids from the from Cabrini Green, from the ghetto, would line up to see him. Because, back then there was no ACA, there was no insurance kind of thing. We had to pay, to have insurance. So the kids from the ghetto would line up to go see this old physician. And he just had a stethoscope. He had his little, lights and everything. And I used to stand there and watch him. And then one day, I was friends with his daughters, et cetera, because I used to take in foster kids too, and et cetera. I asked one of the girls, I said, can I go talk to your dad? And they're like, yeah, go talk to him. So I went there and I said, Dr. Allison, what are you listening for? Because I just graduated my master's degree and I was all full of things in my head. And he goes, are you talking back at church? I said, yeah. I said, that's amazing that you did that. You never got paid, never asked for anything. You just listened. He told me, Rebecca, I'm listening to their heart. I go, I know that. What are you listening for? They're children. They don't have heart disease. What are you listening for? And he goes, I'm listening to their dreams. I'm listening to the things they tell me. I'm listening to their heart, the heartbeat of that child. And he goes, it might make them feel good, even just for that 10 minutes of time I'm spending with them. But just to know that. And I'm like, you know what? That actually changed my life. Listening to the people for that 10 minutes of time, I'm listening to the heartbeat of that person. And I got it. I got that message. So it's not sometimes about the practice. It's about listening. For Indian people, we know that we always hear the drum is the heartbeat of the nation. When you hear that sound, that doctor was doing the same thing and he didn't even know he was talking to a Native person. So this is, just this kind of description could be anywhere, but it's not. Until we start looking at how many people this really affects. So there it is again. And now this is what we teach in school. Actually, we don't. Not even when you get out of school. So again, if we look at the data that comes through, we get a sample. We got COVID people, we have addicts, we have et cetera. As our sample. So we get some characteristics, we get some findings, and we do some experiments. Does it work? Does it not work? So survey, case study, and experiment. And what happens after that? We send them out the door, right? So if we have researchers in the room, what would be great to see is change, policy implementation. Change it. Does it exist? Does it need revision? In every state I've been in, and I've had many conversations with commissioners and governors level on up. Policies need to be changed. There's always a rival policy of the administration. That's not how we do it. You got to follow the process. But what blossoms out of that is a new theory, a new generation of care providers who actually say, I've got my degree, I've got my license, I've got a head on my shoulders. I come from a neighborhood. I come from an area. I come from a time where healthcare has to mean something more to me. That's where it's just so exciting. It's actually fun to see this. So looking at what happened to us, transformation of care. So transforming your care practice. May not always be working for a Mayo facility, Fairview, might drift different places. You might go back and have your own practice. You might work for the federal government. But what happened what happened to us when we were actually put into sequester, when we were put into a closed environment? Now remember, Indians are happy, right? But this came out in 2021, and they said 28.3% of American Indians have a mental health condition. So we got diagnosed somehow, and it got published. We've got to refute those things or redefine them. These are pictures of the few clinics. This, of course, is over on Franklin Avenue. It's the Red Lake. It actually was starting to be, it's just apartments right now, but the bottom level was supposed to be a clinic to treat homeless and the conditions that are prevalent in that on Franklin Avenue in Minneapolis. Across the street at the Minnebamadizewin building is the shelter, Homeward Bound Shelter. And if you ever want to volunteer or take a gander over there, you know, you'll see ODs happening right there, or, you know, various conditions. So when I look at various conditions, when I worked in the shelters, I never really had to address or tell them to don't do drugs. I didn't have to say those simple words. You know, what was more interesting was when we come on in, we'll get intake, we'll go through some vitals, we'll see if you're okay, not having some serious issues going. But what they wanted to talk about was my teeth hurt, or I have GI problems, can't stop having diarrhea, I have STDs. Not one of them said I should get off the meth. You know, we assessed them for things, send them to the doctor, send them to the ER. ERs used to, for the most part, decline us. We can't take them if they're meth and heroin addicts because we don't know if they're detoxed. We won't worry about that. Treat them for their GI issues, treat them for their abscessed teeth, treat them. So we did have talks with the CEOs from the hospital system. When I first started working for this organization I work for now, I did have a talk with the CEOs from Mayo. They wanted to know what my foundation was. How did you come to this point? How do you know these things? Because I do talk to them. I talk to the people who are our family, our relatives, no matter who they are. So this is another 85,000 square foot clinic. This is the Mille Lacs Band Clinic. That row is from again, like a trailer type building to a large building. The issue with brick and mortar buildings is while it might contain instrumentation, support systems, we still need to get out into the community. So usually when I hire staff, I do put that little caveat into their contracts that when there's times of emergency or times of need, we will go. These next few slides are pictures of medicines and plants that are used for the Ojibwe people in Minnesota, Wisconsin. And I grew up with my mom, and because back, you know, in the 20s and 40s, there were no hospital clinics, Walmarts, anything like that you could go and get medicines from. So I very much grew up with plants. My mom's home didn't have running water, you know, or plumbing. So knowing how to live with the woods and having people hunt, that was normal. You know, I carried a gun until I married my husband, and he was like, you can't be doing that. But back where we live in northern Wisconsin, it is, you know, it's what you do. It's all right. You know. So of course, the middle picture is swamp tea, Labrador tea, if you will. This is wintergreen, to keep you alive, vitamin C during this winters, and that's bitterroot on the side. And of course, this man here was a phenomenal advisor, Indian advisor to many of the tribes up in northern Minnesota. And this beadwork band right here is actually, they're bandolier bags, the straps, but they were also our medicine bags. So when you go gathering in the woods, you had a big bag to put your things in, and the beadwork actually told you what it was. So nowadays at powwows, we have all kinds of designs, but back in the day, we actually knew what was in those bags. Yeah. So the value of a bag like that, even back then, was about $7,000 or 2 horses, or depending on there was value to it. But a lot of people don't know that the flowers did indicate what was in there. And so some of the older beadwork, I can actually tell what it was. And this little hut, blue looking hut thing there is actually when we're at Medewan, which is the Grand Medicine Lodge. But when we lose the elders' knowledge, there's lifetimes of knowledge that go away with it. That's why, again, it compels me to always talk to our older people about their lives, because it is important. And again, more plants. So these 3 plants, actually, the first one right here is milkweed. And of course, that ended up on the DOT list to eradicate. But that is our medicine for poison ivy. It grows right next to poison ivy. They say plants are symbiotic and they serve a purpose. And for us, if you get poison ivy, 2 to 3 days, you break open that stem there and put the white substance on poison ivy and it goes away. And the next middle one is arrowroot. So you can eat the tubers that grow up from it. And then the third one, of course, is the purple flower one that actually there's about maybe 10 other medicinal plants that go with it. But they used to use that plant for TB. And University of Minnesota wanted me to bring that recipe in, and I just haven't given it up yet, but it was my grandmother's because they were going to look at it for a possible avenue for COVID. And of course, this is the jingle dress, or the healing dresses, of which the women used to line up before those lodges before the men would go in, and it used to call the spirits. So that's what those dresses are. So when we work with practitioners, we look at increasing, like, for example, increasing Indians into medicine, increase in the health professions. What for? Well, they've always wanted to increase people of color, but also for cultural concordance, especially if you work for a tribal clinic. And there's a study, it's been about 5 years ago now, a Harvard study that actually found almost up to 47% greater compliance with medication if you had a person of color giving it to them. And I know, when my son worked in a pharmacy, and he was just a farm tech, but he said he couldn't believe the people were coming up and showing them their aches and their sores and their different things, because they recognized, they saw the face, they saw him, and they knew him, and they wanted to talk to him. They didn't want to go in the back and talk to the doctor. They'd go rather talk to this young Indian man. And I'm not like, well, that's good. Just, get them connected with who they need to connect with, but anything that would improve our care services. And so again, I just came from a meeting yesterday with federal negotiators for, like the CDC, IHS, AMSA, et cetera, are all there. And again, I was after changing some of the policy levels. And so what we do is, because they're tribal chairmen and everything that are there, and if we don't get a response from these negotiators, these leads or heads of the CMS, it's kind of funny, but the tribal chairmen usually walk out because they haven't been given that due respect. So I remind them of it, even when I talk to institutionalized, administrators, that there is a protocol when you're dealing with Native Americans, that, and especially chairmen or council members, that you have to respect. That's government to government relationship. Doesn't matter what titles, things that you have on right now, it is all about respect and acknowledging that you're actually with a sovereign entity. So, we talk about having doctors take competency. Have you all done competency things here? Do they onboard you with that, or?
Cultural competency?
Yeah, cultural competency.
I want to start.
Okay, so that's kind of what the administration said. They've been kind of lax in that, because it's like, they're like, what's the point? You're coming in for a service, do we stop and talk to you about who you are? And I said, well, it depends, you're going to save a life, but then the life continues. Then what? Are these members from your community here? I would greatly hope, if you want to have more people coming to your facility because you want to have that relationship with your community or with the tribe, that you're near, then I would advise you to spend those few more minutes talking with them or somebody that can come in. So originally, I was going to be doing provider training. That's what I was wondering if it ever happened. So what drives us to compassionate care? Compassionate care. When I speak to like the homeless or individuals that have chronic conditions, meth, etc. I don't like preach at them or anything. I don't talk on and on like this. I address what's really on their minds right now. Maybe they've lost their kids or they've lost where they were staying. Their partner kicked them out for whatever reason. Reminds me of the Johnny Depp trials right now. Who knew? Who knew? Multimillionaire, celebrity, but yet was a victim allegedly of domestic abuse. Whose side do you take, or do you take a side? So when we look at compassionate care, I only had ever one rule working with homeless shelters, and that was to be honest. I can't help if you're not honest. If you tell me you use, great. Then I know 4 days from now I got to get you care or get you something. If you tell me you don't eat sweets, but you're topping that 40% obesity level, I got to get some other tests for you, glandular tests. Why is that important? When you work down in the Southwest, IHS usually will send you out to tribes out in the Southwest where there's the greatest need, but they don't equip you and tell you that there may be other reasons for these conditions. So when we look at a community of people, Native people that have maybe chronic care, Southwest, they always bring up the Pima for having the highest rates of diabetes. I went in my own tribe, went through the computer system and did a chart review, dumped the whole computers out and found out in one village, there was over almost 97% that would qualify for diabetes. Well, I didn't have to go down to Pima Nation. I just had to go in my own backyard, to find this. So when you all work for tribes, a lot of times that computer server is going to tell you a whole different picture of what you're seeing. And it's almost worth the time to talk to the clinical applications coordinator, to the HIM person, to the who's ever running the codes. Run me a code for this. Run me a code for that. And then find out really what the health of the community looks like. Because that's how we found out with the opioid condition. It wasn't your 26-year-olds, 23-year-olds having the issue. Oh my God, it was our elders. They are the ones who topped the need part. So we had to change our whole approach at the clinic. Who do we address first? Who do we flag first? We'll make sure we're actually addressing and doing stop dates for medication. This is, I am getting to the last slides here. So this is your funnel. This is something all put together. It is not dissected. It is not separated. And what I kind of turned this framework upside down because we kind of want to get to compassionate care where we love each other and are inviting and everything too. But actually, I believe it's our starting point. And the wealth of the community, of course, is our capital at the top. But that's because we've done all the other groundwork. We've met with them. We've talked with them. We've not judged. And we've identified the strengths of the people that they're still here. And for Indian people, that really is the qualifier there, is that they are still here no matter what has happened to them. So some research questions, again, what factors can you build when you have your encounters? And what are the outcomes when you have your group meetings, when you go through those grand rounds? What's the outcome there? Or are we still dissecting? And then the impact on the organization. Do we want to change the organization? Can we change the organization? The organization godfathers are not always going to be there. Organizations change. And we saw that in Minnesota, and that decides political factors. If you want something done and you feel, and you have those license and initials behind your name to make a change, you do have that positive effect. And people want to hear that. That's what they want to hear. And then resources. So these are rural resources that I use on DHHS, et cetera. Thank you for your time. If you want to discuss anything or
Just ask one question, other than removing any slides that are your own, would it be possible to get some of these sent to us?
yeah, you can have the slide deck. Yeah. Yeah, I did put that disclaimer up there and disclosure that a lot of these slides are my own, and I was just noticing while they were going through, I didn't put some of the captioning on that, but that's my own beadwork and everything up there. And yeah. So I always do authentic presentations. Yeah.
We've got several questions.
Yes.
So one of the questions that was asked, I want to ask kind of a straightforward one. You had mentioned Dr. Walls' study, and so they were wondering which study that was.
This was a stress and diabetes study. So it's an R01. And if you Google Melissa Walls, she has a lot of great information, a lot of other studies that are available. She's probably the most prolific writer right now for authentic Native American data. She's an excellent speaker too, by the way.
So Cassandra Allen online is just throwing in a ton of great questions
Mhm.
as you've been going through. You were on a roll, so I didn't want to stop you.
Mhm.
At one point, you had mentioned the overwhelming numbers being in urban areas now for Native people, but that comes with an issue in data collection. What are your thoughts on how we can do better on collecting demographic data health for Native people in urban areas?
So Native Americans in an urban area have not relinquished their tribal affiliation. It is okay when you go, like, do a sweep of a neighborhood to go ahead and ask, hey, you're Native American, what tribe are you? Keep a tally. When we were first doing the data down at the homeless encampment, where they said nobody could identify them, absolutely, we went from 10 to 10 to 10 to 10. And I had doctors with me. And we treated things, and they didn't ask about the drugs, not at all. They were asking for asthma. They were asking for inhalers. They were asking for contraceptives. You know, they were off their medications. It was a great opportunity to serve. So demographics is just, it's a little bit more footwork, takes a little bit more of the question. It's okay to ask, what tribe are you? Are you tribal?
So more of a nuanced question, but in relation to what you were talking about with Melissa's study,
Mhm.
what can we do to share those messages that we are happy being who we are as Native American?
We've got to publish. We have to get those community resources out to the people and reinforce that not all data is detrimental to us. Data can be the stepping stone to greater understanding. So there's a different statistical approaches too, by the way, and I do want to get this out there that many of the times we just do straight regression. You know, it exists. That's all regression does, is show you it exists. But when we do discriminant analysis, we can categorize. when we do non-parametric statistics, we're off of that bell curve, because that's where they say Indians don't exist. We're an outlier. We don't show up in the tails, or we're out here somewhere, even in our physique, our BMI. We're out here. We don't qualify. We're fat. We're heavy. We have issues. No, if you do a non-parametric approach, then all of a sudden our numbers become significant to our own people. There's another approach I'm putting out there too now is synthetic data. And I only know that because my son is finishing a PhD in biostatistics. And I asked him, I said, how can we publish these data? We're working with lung cancer. We can't even compare lung cancer statistics, but we should be able to. That's not a step. That's not a hindrance to us. We're just looking in the wrong place. So, son, what can you tell me? And he goes, oh, it's easy. He goes, do AI. He goes, you're bootstrapping already. Yes, but bootstrapping will fragment you. He goes, but AI, synthetic data, will build a number on top of each other until you actually have a number that is equitable to the other numbers.
And then at one point, you had mentioned milkweed being on a list for eradication from the DOT. Do you have the title of that list, or what that, do you recall what that's called?
This would have been in 2014 in the state of Wisconsin because it makes the cows sick. That's actually how I found it, actually. I was looking for plants, because I used to hunt and I used to go gather plants. And I knew through time, I can't gather the plants along the highway anymore. That's where that purple flower, for where I live, that's where it grows in abundance. But because of the pesticide applications, I cannot use that, So I started looking at the DOT list where they're spraying, and I was surprised to see milkweed on there.
Don't have any other questions in the chat.
Okay, all right. Good question, so a lot of things we brought up here are open for publication. If anybody wants to do research projects, anything like that, I know a lot of other researchers that would welcome that.
Other questions in the chat?
This bottom picture here, I guess I didn't point that one out. Do you see that little curly thing in the corner? That's actually the fern that we eat. There's 3 species. 2 of them we don't eat. I don't eat this one, the fat gray one. The other ones will give you heart arrhythmias.
Something specific? Do you eat it for something specific?
Yes, it's like asparagus. Yeah, and you have to cook it over 20 minutes, so otherwise it can be. And you can only eat the fiddlehead on it, the part. Yeah. Well, thank you very much.
Okay, well, thank you very much, Dr. St. Germaine, for your presentation. And thank you all, everyone who has joined us today for this relaunch of our speaker series. I just want to announce that our next presentation will be on August 25th at the noon hour Central Standard Time. So look out for those invites or calendar notifications, but I just want to thank you all again for attending today virtually and in person. And we look forward to seeing you all again.